Welcome to the first session of the 4+2 Diabetes Reversal Strategy. Today we're going to learn about why insulin resistance and type 2 diabetes develop and what you can do about it. This session will cover a lot of ground, but don't worry about it. Over the next 8 weeks we'll cover everything in detail. So let's begin. We all know the conventional wisdom. We've seen the diabetes prevalence rates go up. We've seen the number of Canadians with prediabetes climb dramatically as well. We are undergoing an epidemic of type 2 diabetes. Conventional wisdom says that type 2 diabetes is chronic, progressive disease, and it can be slowed by vigorous use of lifestyle changes and medications, but it eventually results in vascular damage and end organ failure. Medical treatment results in virtually no disease remission. And this is especially true based on the Kaiser study of over 75,000 people where the spontaneous remission rate for type 2 diabetes was less than 1%. With time, medication use and healthcare costs and complications all rise, so it's a pretty dire picture. At 9 years, less than 25% of people can cover diabetes and control diabetes with just one medication. And after 10 to 12 years, over 50% of type 2 diabetics require insulin. So you may be asking yourself, if those are the facts, and they are the evidence that's in the literature, can type 2 diabetes really be reversed? Where does the evidence come for this? Well, the first clue is bariatric surgery. So we've known this actually for quite a long time. In 1992, Poirez et al. Had the first study which showed a 10-year remission rate of about 90% in people undergoing bariatric surgery. So bariatric surgery is surgery, surgically alters the stomach and basically bypasses the stomach. Numerous trials have followed, and they depend a little bit on terms of the procedure and kind of how the trial was structured, but we see a remission rate of somewhere between 30 and 70%, again, depending on that procedure. And what's interesting about this is long-term remission correlates with the amount of fat loss. So weight loss is key to the long-term remission of type 2 diabetes. But glucose control, blood sugar control happens almost immediately. So this information has been out for a long time, and it captured the attention of Dr. Roy Taylor at Newcastle University. And Taylor and his group systematically developed the twin cycle theory. And we're going to go through this because the underpinning of the 4+2 diabetes reversal is this twin cycle theory, which really details a metabolic vicious cycle. And we're going to show how lifestyle behaviors are the key input to the twin cycle theory and how lifestyle behaviors are the way out of this metabolic vicious cycle. Taylor and his group went really from end to end in what I think is probably one of the most impressive sets of evidence ever put together. So everything from cell studies right to primary care reversal strategies. So the direct study. And he even went back to bariatric surgery to show that what he was seeing in his reversals was the same thing that was happening in bariatric surgery. So this is really kind of a tour de force set of evidence, all the way landing into primary care and directly influencing what we're doing in the 4+2 diabetes reversal program. What he found in his direct study when he got into primary care was a very dramatic remission rate. And so really what his hypothesis is that diabetes is a complication of weight gain and excess body fat, not necessarily a permanent condition. It can be reversed, as we see with bariatrics. But it requires, for most people, it requires very significant weight loss. And so in his study, which was a randomized control trial of people with type 2 diabetes, albeit early, so these are people who had type 2 diabetes less than 4 years, but what he found was 86% of those people who could lose 15 kilograms were able to put their type 2 diabetes into remission. So very impressive, very far cry different than the 0.5% of spontaneous remission with conventional medical therapy. Direct isn't the only study. Virta Health and Dr. Susan Hallberg have done a study looking at ketogenic diet, non-randomized, but including longer standing diabetics than those on insulin. And like the direct study and like Taylor's work, they show stunning and dramatic changes. So 12% average weight loss, 94% decreased or eliminated insulin dosage, and 60% of people in their trial had a hemoglobin A1C below the diabetes threshold, meeting the criteria for remission. So can type 2 diabetes really be reversed? Yes. What we see with the reversal of type 2 diabetes is that the blood sugar control happens very, very quickly. So it happens actually before weight loss. And it correlates with changes in liver and pancreas function. And we'll get into the details of this. Long-term remission appears correlated with weight loss and the maintenance of weight loss. So it's very important that we lose weight, but we lose weight sustainably so that the situation doesn't recur. So let's go through this. Let's look at this and unpack this for you. How to think about insulin resistance and type 2 diabetes. Now, we can look at a few definitions of diabetes. So one definition is diabetes is a disorder that disrupts the way your body uses sugar, glucose. This is very true. This covers both type 1 and type 2 diabetes. But let's go a little bit more detail around type 2 diabetes. And type 2 diabetes is a disease of insulin resistance, eventually leading to decreased insulin secretion. So this is clearly true. It just probably doesn't mean a heck of a lot to you guys yet. I will explain these words in detail, but the definition that I like is a definition that comes from Taylor's work. And I think this is a definition that we can hang on to more. Diabetes is a disorder of energy overload. So energy we get from food, energy we store as fat, energy overload means fat. And this is a story of how the body tries and ultimately fails to accommodate this energy overload or fat. And each person's threshold for decompensation is different. And that's why you see people with type 2 diabetes who are very overweight, just overweight, and some people with type 2 diabetes that don't seem to be overweight at all. So we will explain that definition, and you'll come to learn this over the next 8 weeks, and it'll start to mean more and more to you. But let's go back to some foundations and think about how we manage energy. So food really equals energy. That's where we get our energy to live. We get it from food. We get it from the fat in our food, the protein in our food, and the carbohydrates in our food. What's interesting about the human body is we have two different energy systems. We have a glucose system and a fat system. Glucose is the preferred fuel for our brains, but glucose has two major limitations. At high concentration, glucose is toxic. Simply put, glucose is sticky. If you think about it, if you spill a glass of orange juice or a glass of pop on a table, it's sticky. And it's no different when it's in our bloodstream. It sticks to proteins and it causes damage. So only small amounts of glucose circulate at any one time. Now think about this. Normal blood glucose at 5.5 millimoles per liter is the equivalent of 1 teaspoon of glucose circulating in our body. So glucose circulates, but not very much at one time, right? It's toxic, it's sticky. So we don't like to have a lot in the bloodstream, and our body will do a lot to control that. The other thing that's fascinating about glucose is glucose can be stored as glycogen. But the challenge here is for every gram of glucose, there's 3 grams of water stored with it. And so 1 day's energy stored as glycogen is the equivalent of 2.5 kilograms. So this storage with water prevents us from storing very much glucose. Fat, on the other hand, is our slow fuel. So it is actually very, very efficient for storage because it doesn't get stored with water. So 1 day's energy is 0.278 kilograms, or less than 10% of the equivalent of glucose. So it's very efficient. And we have an unlimited capacity for storage. So whereas glucose and glycogen we can store in our liver and muscles in limited amount, with fat we can store it in our fat tissue and we can make more fat tissue. The healthy storage, the subcutaneous kind of lower body storage, kind of pear-shaped storage, is is limited. Um, and the unhealthy storage, unfortunately, the abdomen and upper body seems to be unlimited. And so we get the two different shapes that will correlate with metabolic health. And we'll get into that in more detail. Fat's also the preferred fuel for the heart, intestines, and muscle, well, at least muscle at rest. So we have these two fuel systems. And when we think about fuel storage, this is something that's really interesting, right? So if you kind of look at glycogen or stored glucose, it's that little gas tank on the front of this fuel tanker. And the adipose is the big tank in the back. So when you look at our two fuel systems, they're quite different in terms of our ability to store. And so this is kind of one of the things that becomes a key when we start to think of these energy systems getting overloaded. Because remember, we're talking about the definition of type 2 diabetes and insulin resistance as being a state of energy overload. So when we eat food, we digest it. So we break down the food into units that can be absorbed into the blood. And those three macronutrients break down fats into fatty acids, proteins into amino acids, and glucose, carbohydrates into glucose. The fat is absorbed directly into the systemic blood via the lymphatics, kind of a quirky system that always still amazes me. But essentially what happens is fat goes into general distribution and it's available to cells immediately after absorption, and it'll get circulated. And the cells that use fat will pick it up and use it for energy. Some of that fat will get stored in fat tissue or adipose tissue via the role of insulin. And we'll talk more about insulin, but insulin is a storage hormone that also helps us store fat. So fat goes directly into the systemic circulation. Protein is really not our preferred source of energy. So protein does have energy, and protein can be converted into energy. So we can convert protein into glucose through a process called gluconeogenesis. We also, if we tend to eat too much protein, in the case of energy overload, we'll convert it into fat. But generally why we eat protein is to make other proteins. So we eat protein to make muscle and build muscle and repair muscle. But if you think about all the or most of the very useful molecules in our bodies, from neurotransmitters to hormones to enzymes to receptors, they're all proteins. So we need to eat a certain amount of protein to be able to repair, maintain, and build new proteins. Protein, there are 9 essential amino acids. So proteins are made up of amino acids. They're 9 essential ones that we have to eat. We can't manufacture these ourselves. And then there's carbohydrates. So carbohydrates are made up of sugars, starches, and fiber. And really kind of the best way that I like to look at it is from the standpoint of, are they simple or are they complex? And really simple means that they convert to glucose very quickly. Complex means that they convert to glucose either over a longer period of time, or in the case of fiber, they don't actually get absorbed and they serve as fuel for our microbiome. The other way to think about simple and complex is what it does from an insulin response. So simple will generate an insulin response, and complex tends not to generate much of an insulin response. So let's talk about insulin. Now, most people think of insulin in terms of its context in type 1 diabetes. So type 1 diabetics do not make insulin and they have to take insulin as a medication. So insulin very much does control blood sugar. And when you eat sugar or carbohydrate that gets broken down into glucose, that presence of glucose in the small intestine will stimulate the pancreas to release insulin. Insulin acts on the body cells, especially kind of the liver, fat, muscle, and these are going to be the key areas that we keep coming back to. It acts on the body cells to absorb the basic units from the food. So it'll absorb the glucose, so that's how it regulates blood sugar. But it will also act on cells to absorb fatty acids. It'll also act on cells to absorb amino acids. It promotes storage, so promotes the creation of glycogen, fat, and proteins from amino acids. And it stops the breakdown of those stored forms. So it stops the breakdown of glycogen, fat, and protein. If you're going to remember anything about insulin, just remember it's a storage hormone. So when there's insulin around, you're going to store energy. And when there's insulin around, you're not going to access your stored energy. So insulin wants to store that energy. So let's look at what happens if we eat a bowl of basmati rice. So this bowl of basmati rice is about 210 calories. There's a little bit of protein in it, not very much fat, and quite a bit of carbohydrate, not too much fiber. So when we eat this, the carbohydrates are actually pretty simple carbohydrates. Um, and those carbohydrates are the equivalent of 10 teaspoons of glucose. Remember, circulating in our blood right now is only 1 teaspoon of glucose. So this bowl of basmati rice is going to deliver 10 times the amount of glucose that is currently circulating in our body. So what's going to happen? Well, our pancreas is going to release insulin. It's going to release, the beta cells in the pancreas will release insulin in response to the glucose levels. So as we start to absorb that glucose from the basmati rice and our blood sugar goes up a little bit, the pancreas will be on it and it'll release insulin. And the goal is to tightly control the glucose levels because remember, glucose is toxic, it's sticky. So the first place that glucose will want to go is the muscle. So normally the muscle takes and absorbs 80 to 90% of the glucose and it stores as glycogen for future activity. So the muscle very much is a glucose sink. It is, provided we're active, it is there to absorb a lot of the carbohydrate that we eat. The liver also stores glucose as glycogen, but the capacity here is really limited, right? Only 150 grams of glycogen stored in the liver, which is about 30 teaspoons. So not a tremendous amount, but we can store some in our liver as glycogen. And then any remaining glucose is going to get turned into fat, and this will actually happen in the liver. So the liver will turn it into fat. And that's the way it's supposed to be, right? So we eat, we store the energy, and we have these buffers. So we're able to store the energy, the carbohydrate energy, we're able to store very easily as glycogen. And when that's full, we start to store it as fat. The fat that we eat will either go for energy use, or if it's extra, it'll go for fat as well. What happens when we're not eating? So when we're not eating, the liver's job, and this is really critical. The liver's job, the liver's number one job is to maintain blood glucose. If the liver stopped doing this, we would actually die within minutes. So incredibly important job. And so the liver essentially will maintain this blood glucose level of 5.5 millimoles per liter or less, kind of at fasting. That's equivalent to 1 teaspoon of sugar. And actually what seems to happen is our bodies use kind of on average when we're fasting about 2 teaspoons per hour. Our brains use a teaspoon per hour and our bodies use another teaspoon. So our liver is kind of producing these 2 teaspoons every hour as the body uses this. And this is under control of the pancreas. So the pancreas will release glucagon to kind of speed up the process. And insulin, remember, insulin is a storage hormone that wants to stop kind of the breakdown of glycogen into glucose. Insulin will slow things down, right? So kind of under balance, we'll maintain our blood sugars. And the glucose will come from glycogen breakdown. And if the glycogen gets low, it'll come from gluconeogenesis. Remember, that's the process that we can turn proteins, fats, or lactate into glucose. And so this is what happens when we're fasting. We kind of tick along and our liver produces about 2 teaspoons per hour and our brain uses that and our body uses that. And it's all kind of kept under control by our pancreas. So what happens when we develop insulin resistance in type 2 diabetes? So first of all, insulin resistance it's kind of an opaque term. I find that it's one that gets used a lot, and a lot of people don't really quite understand what the net impact of it is. I kind of like to sometimes say it's really kind of this when insulin doesn't work, when the receptors become resistant to insulin, the bottom line is it takes more and more insulin in order to store the same amount of glucose. So in other words, in order to keep glucose levels the same, we're going to get higher amounts of insulin circulating. Insulin resistance takes place over time for a variety of reasons. So When you look at insulin resistance, if you look at a 20-year-old versus a 60-year-old, there's a difference. So at 20, we're very insulin sensitive, and at 60, we're less so. Genetics, for sure, right? We see this where there is a predisposition towards insulin resistance in people who have it in their families, as well as certain ethnicities will have a higher rate of insulin resistance, presumably on a genetic basis. But we also start to see insulin resistance from weight gain. So when people gain weight, sedentary behavior when they're not active, stress and poor sleep, and poor nutrition. So it happens for a whole variety of reasons. And for most people, it's actually the whole combination of these things that leads to insulin resistance. But the key to this is it happens in a context of energy overload, too many calories over time. Now, the definition of energy overload for any one individual is individual, right? So some people can handle a lot more energy because their buffers can handle it, but others can't. And these energy buffers, so we've already seen that the muscle will be the buffer for the glucose system, and fat is the buffer for everything because we can just store an unlimited amount of fat or seemingly unlimited. But these energy buffers get overwhelmed. And this is the key issue in type 2 diabetes and insulin resistance. The energy buffers get overwhelmed. And when the energy buffers get overwhelmed, we start not being able to store that energy in a healthy fashion. And so the fat ends up in the wrong places. So we start to get this concept of ectopic fat. Just think fat in the wrong places. Um, Fat in the muscle cells, actually making insulin's job harder at the muscle. Fat in the liver, causing insulin resistance at the liver. And finally, fat in the pancreas, affecting the ability for the pancreas to release insulin. And so fat in the wrong places is at the heart of what we see in insulin resistance. So this bowl of basmati rice is 10 teaspoons, right? 10 times the amount of glucose. So let's see what happens during insulin resistance. So the pancreas goes and releases its insulin to try to control the glucose levels. The muscle is going to do its job, but in insulin resistance, it can't actually absorb this. The muscles may not be sensitive to insulin, so they may not pick up the amount of insulin or amount of glucose that they normally do. This is going to mean that the liver, which can take some glucose and store it as glycogen, but it's got a capacity limit. The glucose buffers are now overwhelmed. So more and more of that glucose is turned into fat. But with rising insulin levels, so remember, if in insulin resistance, insulin receptors aren't working as well for a whole bunch of reasons, but as they're not working well, the insulin levels are going up, and we're going to get this one-way storage of fat. We can store the fat, but insulin is going to prevent us from burning the fat. And so we start to get the weight gain. Over time, the enlarged fat cells lose their ability to store more fat in kind of the healthy areas. So fat starts to spill over, and the fat starts to get stored where it shouldn't be. So you start to see fat in the abdominal area, the visceral or belly fat, that apple shape, and you start to see it in the cells of the muscle, liver, and pancreas cells. And all of this aggravates the insulin resistance in those tissues, making things worse. And it's really key to kind of bring this concept up, right? When we look at storing fat, we've got two ways of kind of storing more fat. We can increase the number of fat cells, and we can increase the size of our fat cells. The challenge is our healthy fat depots, our healthy places to store fat. The number of fat cells is largely determined by age 2. So it's determined by genetics, it's determined by epigenetics of in utero effects, and it's determined by early childhood development. But by age 2, it's kind of set. So some people have lots of fat cells that they can fill up, and they are able to buffer much, much more energy. Other people do not have that ability. And so they're, in our healthy fat, the only thing they can do is increase the size of those fat cells. So they will find that they cross over their thresholds sooner. The unfortunate part of this is we have the ability to create new fat cells in the abdominal or visceral area, in the unhealthy area. And so we start to store fat in the unhealthy area because of this fact. And so this personal fat threshold is really kind of the concept of the fat buffer being overwhelmed. And this is the difference between being overweight and being sick. So somebody can be overweight, but they can be storing all of their energy within their fat buffer, uh, not storing fat in the wrong places, and metabolically be healthy. Another person can weigh less, have less overall percentage body fat, but because their kind of healthy fat is overwhelmed, their fat buffer is overwhelmed, they're storing it in unhealthy places and they're actually sick and they have insulin resistance. Very, very key concept. So back to our story, the liver, right? Now, the unabsorbed glucose, so the glucose that the muscles cannot absorb, right? So the muscles are our glucose buffer. So that unabsorbed glucose is going to end up back at the liver, as well as the fat, the free fatty acids that are spilling out from the fat cells. That is going to ultimately have to be dealt with by our liver. And so the liver will take this and it will make triglycerides, which is fat, and export that in the blood. Those triglycerides will kind of go around the body again, but the healthy fat cells are full, so it'll largely end up creating more visceral fat. The liver also may end up storing some of that, and you may get fatty liver, or both, and most likely it will be both. Now, the pancreas does not sit unaffected here. So the pancreas, normally releases insulin in response to glucose level, but with insulin resistance, the pancreas starts to absorb some of this fat that's spilled over from the liver and from the overflow from the fat cells. And the beta cells themselves become dysfunctional, and now they can release less insulin. And over time, fewer insulin cells have to produce higher and higher insulin levels. And eventually it breaks down and they no longer can maintain blood sugar control. And that's when you start to see diabetes. So we've described a process of these kind of four blows, right? So our muscles are affected, our fat tissue is affected, our liver is affected, and our pancreas is affected. Looking at this from another perspective, energy overload or too many calories, the muscles not taking up the glucose, the fat spilling over, all of these things are going to result in liver fat, right? So they're all going to increase the fat in the liver. When liver starts to get fatty and we start to get a buildup of fat in the liver, it doesn't respond as well to insulin. So remember, when we're fasting, the liver is producing blood sugar, and it needs to be in balance between, the production needs to be kind of kept at balance at 5.5 millimoles per liter, but it has to be responsive to insulin in order to keep it in balance. So fat in the liver means the liver does not respond as well to insulin, which means the blood glucose goes up a little bit, which results in the pancreas increasing that insulin level, right? So now insulin levels have to go up higher to keep that under control. And so that's the liver cycle. The liver also, as we said, exports fat, right? So it exports the triglyceride. So the VLDL, or very low density lipoprotein, packs up triglyceride, which is fat, exports it, and some of that fat ends up in the pancreas. And when it ends up in the pancreas, it causes the beta cells to be dysfunctional, and they don't release as much insulin. So we start to get the decreased insulin response. And so this is the second part of the cycle. So this is Roy Taylor's twin cycle, theory, and just kind of unpacked and showed kind of what happens over time. So how do we stop this cycle? Well, we get rid of the liver fat. If we can get rid of the liver fat, we can restore insulin sensitivity at the liver, and this will decrease our basal insulin requirements and help normalize fasting blood sugars. And if we can stop and get rid of the pancreas fat, we'll improve our insulin response to meals. And this will normalize our post-meal blood sugars. Sounds good. How much fat? Well, the studies that Taylor and his group have done and others show that the amount of fat in the liver when you see a high degree of insulin resistance in type 2 diabetes is about 400 grams, or it's just like a pound of butter, right? So a pound doesn't sound too much, does it? Right? So, but think about a pound tucked under your right rib cage where your liver is, and maybe it is a considerable amount. Our challenge is, though, we don't have any direct way to simply lose liver fat. And so when you looked at the direct study and when they looked at a primary care intervention to help people lose weight and reverse their diabetes, what they found was 86% remission if they lost 15 kilograms or 30 pounds, right? Or 30 plus pounds. So we have to lose more weight in order to pull out that liver fat. Let's look at this from another perspective. So let's take glucose and insulin over time. And so the normal blood glucose, as we've said, is 5.5 millimoles per liter, where this represents our teaspoon of glucose. And in insulin resistance, what we've said is this process, this twin cycle process, clicks along, and what you start to see is climbing insulin levels, right? But notice the blood sugar's normal, right? So if we went to our family doctors and they checked our sugar, they say, nope, your blood sugar's normal. There is no diabetes here. But there is insulin resistance. And probably the biggest sign for people if they want to try to figure out where they are on the curve is how much triglyceride is in the blood, right? So remember the liver in the liver cycle is pumping out triglycerides, pumping out fat. So elevated triglycerides is often really our first clue here. The other clue, of course, is waist circumference. If you're starting to store fat in unhealthy places, this process is starting to begin. So as this goes on, the pancreas just releases more and more insulin. So it's just pumping along, doing its thing. But at a certain point, it can't keep up. So the second part of the twin cycle kicks in, and the pancreas starts to be affected. It can no longer produce unlimited amounts of insulin. And you notice in the red there, the blood sugar starts to climb up a little bit. And so this is prediabetes. Prediabetes takes about 10 to 15 years to develop. So this process takes a long time to develop. It doesn't just happen overnight. And at the time of prediabetes diagnosis, insulin levels are 2 to 3 times normal. And what they see is about a 50% reduction in pancreatic beta cell function at this point in time. Play this out a little bit further, and we get a diagnosis of diabetes. And at this point, at the time of diabetes diagnosis, you see an 80% reduction in pancreatic beta cell function. So as we kind of look at this, we see this first phase really being kind of this insulin resistance phase. And this is kind of the quiet phase, right? We don't often kind of intervene here. But once the pancreas can't keep up with insulin production, that's when we start to get the abnormal blood sugars. And that's often when we start to talk about prediabetes and diabetes. But I would argue this process takes place way earlier, and it's something that if we want to prevent, we should be attacking much, much earlier in the cycle. So insulin resistance really results in hyperinsulinemia. Okay, another big word. Too much insulin, right? And so this is really, really important because too much insulin on its own is actually a problem, right? So there's a condition called metabolic syndrome, which was recognized by a Stanford physician, Gerard Reven, back in the 80s. And really kind of what he noticed was just kind of a collection of kind of observations. And really what we see here is only one of the 5 things is actually abnormal blood sugars. And so if we kind of go back to what we're looking at in terms of these 2 cycles, in insulin resistance, as long as the pancreas is keeping up, the blood sugar is going to be normal. Some people can do that for a long time. Some people can't do it for very long at all. And what we see in metabolic syndrome is kind of 3 out of the 5 are required for a diagnosis of metabolic syndrome. We see these other attributes which are super important. So the increased waist circumference, the high triglycerides, the low HDL cholesterol. Those 2 are related to each other, by the way, and the high blood pressure. And so if we have a super pancreas that can keep up for a long time, we may never see the abnormal blood sugar. But high levels of insulin on its own has many of the same complications as type 2 diabetes. And in fact, very, very similar rates of coronary heart disease, which is the #1 cause of death for diabetics. So too much insulin on its own, even if blood sugars are controlled, is not a good thing. So we've described these 4 blows and these 2 phases. And there are two other things in our 4 plus 2. So remember, we said it's 4 plus 2. So you can kind of see where our 4 are coming from. Going to be related to these 4 belows. But our plus 2 relate to stress, is blow number 5. And stress drives cortisol, and stress also drives appetite. So in conditions of stress, we've got higher levels of cortisol, we've got higher appetite, which contributes to weight gain and energy overload. And blow number 6 is lack of sleep. And again, we'll see increased levels of cortisol and increased appetite. So making energy overload more likely. And cortisol is the important kind of common link between these two on the plus 2. And cortisol we'll call our stress hormone. But cortisol really, its job is in stress to mobilize energy. And in many ways, it counteracts insulin. So it increases glucose production by the liver. It actually increases the muscle breakdown, so to turn protein into glucose. It increases peripheral fat to turn fat into glucose. And if we're not using that energy, you see an increased accumulation of visceral fat. So if the stressor is that we're running from a bear, we're probably going to use that extra mobilized energy in our sprint. But if the stressor is our boss or an email, then maybe we're not going to use that energy. And so we're going to break down muscle and peripheral healthy fat, and we're going to turn it into visceral or abdominal fat, only making things worse. So really kind of the bottom line here is anything that chronically raises cortisol will worsen insulin resistance. So we've laid out kind of the foundations or why this happens. And you can start to see, you can start to imagine kind of where we're going to intervene in order to address this from a lifestyle behavior perspective. So the first part of the strategy is we want to eat in such a way to lower the amount of insulin. And so if we can not require as much insulin, we can think about that curve. If our blood sugars are elevated because our pancreas can't produce enough insulin, if we change the amount and way we eat in such a way that we require less insulin, maybe our pancreas can actually control the blood sugar just because of that change. So we want to decrease the carbohydrates, especially those simple carbohydrates that drive the insulin response. And we also want to increase fiber. So that we will unpack in another session. Second part of this is we want to use our muscles. So clearly we've seen that our muscles are the glucose buffer for us. So if we increase our exercise and activity, we can keep our insulin sensitivity in the muscles and increase the glycogen store in the muscle. So this is super useful. And so we, by using our muscles, can restore the muscle's role as the glucose sink. The third is our poor liver. We've got to be kind to that liver, right? So we're seeing in the twin cycle theory that the liver is kind of the key player here, right? And so it's already dealing with glucose spillover from the muscle. It's dealing with fat spillover from fat cells that can't take up fat. So we have to be sure that we're not doing other things that drive fat into the liver. So the big culprits are sugar, and really it's the fructose component of the sugar, alcohol, and also gut health. What we see with poor gut health is inflammation in the liver that leads to fat. And so we will again unpack this in another session, but we have to be kind to our liver. The fourth is, and it's obvious from the direct study, right? We've got to restore fat burning, and we've got to get that fat out of the liver and pancreas. And that's probably going to take a fairly significant weight reduction. So kind of the combination of reducing the insulin levels through what we do with our eating, increasing our activity, less alcohol and fructose. We then can use some strategies around reducing our intake using intermittent fasting or time-restricted eating to accentuate and restore our fat burning. And this is all to stop the cycle, right? Get rid of the liver fat, get rid of the pancreas fat, get rid of that pound of butter. So that's the 4. Eat to lower insulin, use your muscles, be kind to your liver, and restore fat burning. The plus 2 are simpler in a way. Learn to de-stress, but maybe that's not so simple, and improve our sleep. And so we will, again, in other sessions, kind of unpack those. So that is the 4+2 diabetes reversal strategy introduction. We will go through in future weeks, and we will go through this in much, much more detail. Thank you.